Hello there. So now we'll move further in gastroenterology. So here we have a 27-year-old woman who comes to the hospital with pain and distension of her abdomen. The pain started a few days ago. It has been worsening over the past 24 hours. Now she gives a history of recent bloody diarrhea. She has been suffering with chronic diarrhea and abdominal cramps for a few months associated with fever and malaise. Her diarrhea is often episodic with periods where she has normal stool consistency for a few days. However, she feels greatly inconvenient during episodes where she has increased frequency of defecation. An erect abdominal X-ray was requested performed which shows mucosal edema, dilated transverse colon, and her temperature is 38.5, pulse rate 105, blood pressure 160, white cell count is 16.3 raised, CRP is also raised 125, hemoglobin is 100, slightly less. What is the single most likely diagnosis here? So here we'll be studying about ulcerative colitis, and also we'll also be touching a little on Crohn's disease versus ulcerative colitis. First of all, ulcerative colitis is often episodic and it presents with chronic diarrhea that can be bloody. Uh, Systemic symptoms include fever, malaise, and in moderate to severe attacks, blood test would show raised WBC count and CRP with anemia. Chronic diarrhea would be there, which would be bloody. Therefore, anemia would be there, iron deficiency anemia. And blood test will show raised white blood cell count, and CRP will also be raised. Systemic symptoms can include fever, malaise, and the features that she presents within the hospital are consistent with a toxic megacolon. This is characterized by a very dilated colon accompanied by abdominal distension, abdominal pain, and in some cases, shock. Toxic megacolon is one of the well known complications of ulcerative colitis. So, first, we understood about that ulcerative colitis can be episodic, and it presents with chronic diarrhea, which can be bloody, and systemic symptoms can be fever, malaise, and blood test can show raised WBC count, CRP would be raised, and due to bleeding, due to bloody diarrhea, there will be anemia, iron deficiency anemia. Here, what we are seeing, the symptoms can be consistent with a toxic megacolon. There is a very in toxic megacolon, there is a very dilated colon accompanied by abdominal distension. There is abdominal pain, and in some cases, the patient may also go into shock. And this toxic megacolon is one of the most well-known complications of ulcerative colitis. So ulcerative colitis, now here treatment. Treatment is based on the severity. The must know is mild to moderate symptoms. First line we will give treat with topical aminosalicylates, that is mesalazine, so as to induce remission. And yes, so treatment would be based on the severity. Mild to moderate symptoms, first line we will treat with topical aminosalicylates such as mesalazine so as to induce remission. Mild to moderate symptoms usually involve a bowel movement of less than 6 times a day. So bowel movement of less than 6 times, that is diarrhea episodes less than 6 times a day, it would be counted till moderate, mild to moderate, till 6. More than 6, it will be serious. So we have to take care of the number of episodes of diarrhea. Mild to moderate symptoms usually involve bowel movement for less than 6 times in a day. Mild to moderate symptoms, first line we will give topical aminosalicylates such as mesalazine so as to induce remission. Okay, that is a treatment of ulcerative colitis. Now we will study a little about Crohn's disease versus ulcerative colitis. So it is important to know the difference between ulcerative colitis and Crohn's disease. Key differences are: some key differences here between Crohn's disease and ulcerative colitis are Crohn's disease, it can affect any part of the GI tract from mouth to anus. Usually, it has non bloody type of diarrhea. Abdominal mass is palpable in the right iliac fossa. There are increased goblet cells and increased granulomas on histology. Weight loss is more prominent. In Crohn's disease, there are transmural skip lesions, cobblestone appearance, or endoscopy. In Crohn's disease, there are transmural skip lesions and cobblestone appearance on endoscopy. These all are like characteristic features of Crohn's disease: transmural, skip lesions, and cobblestone appearance. Now, ulcerative colitis affects the mucous membrane starting from the rectum and it proceeds proximally. There is bloody diarrhea, which is more common compared to Crohn's disease. Abdominal pain is there in the left lower quadrant. In ulcerative colitis, it will be towards the left. In Crohn's disease, it will be towards right. So, ulcerative colitis, abdominal pain is there on the left lower quadrant. Decreased goblet cells and decreased granulomas on histology. Primary sclerosing cholangitis, more common. And then there is loss of ostration, drain pipe colon, seen on barium enema. Toxic megacolon can be a complication of ulcerative colitis, and in this there is loss of ostration and drain pipe colon, seen on barium enema. It will be dilated. Loss of ostration should be there, drain pipe colon is seen. So this is about ulcerative colitis versus Crohn's disease. Let's just go through this quickly. So in Crohn's disease, there are skip lesions and it can occur anywhere in the GIT. Whereas in ulcerative colitis, we have continuous lesions and it is only affecting the colon. It is Crohn's disease usually non-bloody diarrhea, ulcerative colitis bloody diarrhea, histology transmural ulcers and granuloma. There are transmural ulcers and granuloma. In Crohn's disease, granuloma are there, increased goblet cells, and transmural ulcers are there. Whereas in ulcerative colitis, we have abscess, crypt abscess. Yes, in ulcerative colitis, we have crypt abscess. Now, complications of Crohn's disease will be fistulas, stricture, Fistulas, stricture, colorectal cancer, osteoporosis, complication of ulcerative colitis, colorectal cancer, toxic megacolon, osteoporosis. So here fistulas and stricture, and here colorectal cancer, toxic megacolon, osteoporosis. On endoscopy, here in Crohn's disease we see cobblestone mucosa, here loss of ostration markings and drain pipe appearance. Cobblestone mucosa and loss of ostrations and drain pipe appearance. Treatment in Crohn's disease, glucocorticoid, azathioprine or mercaptopurine, infliximab, adalimumab. In ulcerative colitis, mesalazine, corticosteroids, cyclosporin. Crohn's disease, we will give glucocorticoids, infliximab, adalimumab, azathioprine, mercaptopurine. Here, ulcerative colitis, we'll give mesalazine, aminosalicylates such as mesalazine, corticosteroids, and cyclosporin. Now, further, here we can see the most commonly affected place in Crohn's disease. It mainly affects Crohn's disease can affect any part of the GIT, but it mainly affects, or most commonly, it involves ileum. Crohn's disease most commonly involves ileum, whereas ulcerative colitis, it usually affects colon, but most commonly it is involving rectum part. Most commonly it is involving the rectum, and Crohn's disease involves ileum and rectum. Now, location of the disease. Crohn's disease can be present from mouth to anus, and ulcerative colitis, it starts from rectum and it proceeds proximally. Now, Crohn's disease, ulcerative colitis, Crohn's disease, we have typically non-bloody type of diarrhea. Of course, bloody diarrhea can also occur. It can also occur. There are chances, but usually it is non-bloody type. Ulcerative colitis, typically we have bloody diarrhea. Now, toxic megacolon, which is a complication of ulcerative colitis, and rarely it is a complication of Crohn's disease. Toxic megacolon is mostly a complication of ulcerative colitis. So here we see loss of ostrations, we see dilated colon, drain pipe appearance on endoscopy. See lead pipe, we can see here, drain pipe or lead pipe appearance, loss of ostrations, dilated colon. Patient will have abdominal pain, abdominal distension, patient can go into shock. Then we also see thumb printing here. So X-ray features would be thumb printing and lead pipe appearance on barium enema. Two things we see here. So again, Crohn's disease can affect any part of the GIT from mouth to anus, usually non-bloody diarrhea, abdominal mass palpable in right iliac fossa, increased goblet cells and granulomas on histology, weight loss more prominent, transmural skip lesions, cobblestone appearance. Ulcerative colitis affects the mucous membrane starting from rectum, proceeds proximally. Bloody diarrhea is more common compared to Crohn's disease. Abdominal pain is present on the left lower quadrant. Decreased goblet cells, decreased granulomas on histology, primary sclerosing cholangitis. Then toxic megacolon can be a complication. Loss of ostrations, drain pipe colon are seen on barium enema. X-ray findings, these are. And further, as we saw, here skip lesions, and anywhere in the GIT, here continuous lesions only affecting the colon, non-bloody diarrhea, bloody diarrhea, transmural ulcers and granuloma, here cryptepsis. Complication can be fistula, stricture, colorectal cancer, osteoporosis. Here it can be toxic megacolon, colorectal cancer, osteoporosis. Here we have cobblestone mucosa on endoscopy, cobblestone appearance. Here we have loss of ostrations and drain pipe appearance. Treatment here would be glucocorticoids, azathioprine or mercaptopurine, infliximab, adalimumab. Here we have mesalazine, corticosteroids, and cyclosporin. Most commonly affected places in Crohn's disease, it is ileum. In ulcerative colitis, it is rectum. Crohn's disease, mouth to anus, anywhere in the GIT. Ulcerative colitis starting from rectum proceeds proximally. Crohn's disease, typically non-bloody type of diarrhea. Bloody can also occur. Ulcerative colitis, typically bloody diarrhea. Toxic megacolon, which is a complication of ulcerative colitis, rarely Crohn's disease. X-ray findings would be lead pipe appearance or drain pipe appearance and thumbprint markings or thumb printing. Okay, so now let's study a little about Crohn's disease. So in Crohn's disease, there will be diarrhea, non-bloody type of diarrhea. There will be fever, tenderness at the right lower abdomen, mass at the right lower abdomen. Palpable mass at the right lower abdomen, tenderness at the right lower abdomen, diarrhea and fever. Fecal calprotectin differentiates inflammatory bowel disease from irritable bowel syndrome. So it is fecal calprotectin which differentiates inflammatory bowel disease from irritable bowel syndrome. Now colonoscopy is the best diagnostic test here. CT scan if the patient develops an abscess. We know in Crohn's disease we find crypt abscesses, whereas in uh, in ulcerative colitis we find crypt abscesses. Yes, in ulcerative colitis we find crypt abscesses. Here we find transmural ulcers and granulomas. So Crohn's disease important points: diarrhea, fever, tenderness at the right lower abdomen, mass at the right lower abdomen. Mass can be due to abscess formation. Tenderness can be due to ileitis. Tenderness is due to ileitis. Mass is due to abscess. There is diarrhea and fever. Now, colonoscopy is the best diagnostic test for Crohn's disease. Colonoscopy is the best diagnostic test for Crohn's disease. Fecal calprotectin helps in differentiating between inflammatory bowel disease and irritable bowel syndrome. Fecal calprotectin. Now, CT scan can be used if the patient develops an abscess. And here, ulcerative colitis, we have to first know based on the severity, mild to moderate symptoms, usually less than bowel movements less than 6 times a day. Then mild to moderate, treat with topical aminosalicylates such as mesalazine to induce remission. Okay, so that is about ulcerative colitis and Crohn's disease. Let's move further. A 25-year-old woman complains of diarrhea, abdominal cramps for the past 8 months. She says her diarrhea has recently become bloody. Biopsy was performed. Colonic mucosa show crypt abscesses. So these are like characteristic features. What is the single most likely diagnosis? Now her diarrhea is bloody. She has crypt abscesses. As we understood, crypt abscesses are present in ulcerative colitis, whereas in Crohn's disease we have transmural ulcers and granulomas. Transmural ulcers and granulomas. Crypt abscesses are present in ulcerative colitis. Okay. So, crypt abscesses or crypts of Leverkusen, as we say, these are typical of ulcerative colitis. Though these are not diagnostic, these are mucosal crevices that are seen in the normal GIT. But in ulcerative colitis, they get clogged up with neutrophilic exudates forming crypt abscesses. These are not real abscesses and they do not require surgical drainage. Okay, so crypt abscesses, which are found in ulcerative colitis. Crypt abscesses or crypts of Lieberkuhn. These are typical of ulcerative colitis. Though these are not diagnostic, these are mucosal crevices which are seen in the normal GIT. Just what happens that in ulcerative colitis, these crypts of Lieberkuhn, they get clogged up with neutrophilic exudates, forming crypt abscesses. So crypts are normal, present in normal GIT, that are crypts of Lieberkuhn, but in ulcerative colitis, these crypts get clogged with neutrophilic exudates, due to which they turn into crypt abscesses, forming crypt abscesses, and these are not real abscesses and they do not require any surgical drainage. Okay, so now let's move further. A 33-year-old woman presents to the emergency department with right upper quadrant pain for the past 7 days. The pain is constant, gradually worsening over the past few days. The pain radiates to the back, is usually seen to be worse after eating meals. She feels nauseous, has vomited twice today. She has no history of any liver or gallbladder disease. On examination, there are no signs of jaundice. On palpation of right coastal margin at the mid-clavicular line, her breathing is interrupted due to tenderness. So, on palpation of right coastal margin at mid-clavicular line, her breathing is interrupted due to tenderness. Temperature 37.6, heart rate 90, hemoglobin is 120, white cell count is 13, platelets 350, CRP 30, amylase 30, bilirubin 59, ALT 189, ALP 409, albumin 39. So here we will study about acute cholecystitis. So acute cholecystitis usually follows stone impaction. Acute cholecystitis usually follows stone impaction in the neck of the gallbladder, which may cause continuous epigastric or right upper quadrant pain, which is referred to the right shoulder. And there can be vomiting, fever, local peritonism. Occasionally, right upper quadrant mass is also palpable. That is distended gallbladder or an inflammatory mass surrounding the inflamed gallbladder. The main difference from biliary colic is the inflammatory component. That is peritonism, fever, and elevated white cell count. So in biliary colic, we do not have inflammatory component. Whereas in acute cholecystitis, we have inflammatory component. So fever is there, white cell count is raised due to inflammation, peritonism is there. If the stone moves to the common bile duct, then obstructive jaundice and cholangitis can also occur. As we studied, acute cholecystitis occurs due to impaction of a stone in the neck of the gallbladder, which may cause uh, impaction of the stone in the neck of the gallbladder, and it can cause continuous epigastric or right upper quadrant pain. Continuous epigastric or right upper quadrant pain, which is referred to the right shoulder, and there is vomiting, There is fever and local perotinism. We can also sometimes palpate right upper quadrant mass, which is palpable. It can be distended gallbladder or it can be an inflammatory mass surrounding the inflamed gallbladder. Okay, so now if this stone moves to the common bile duct, then it can cause obstructive jaundice or cholangitis as well. The main difference from biliary colic is the inflammatory component. Fever, elevated white cell count, perotinism. Now, Murphy's sign is positive when you lay two fingers. What is Murphy's sign? So when you lay two fingers over the right upper quadrant, ask the patient to breathe in, which causes pain and arrest of inspiration as an inflamed gallbladder impinges on your finger. It is only positive if this same test in the lower upper quadrant does not cause pain, in left upper quadrant does not cause pain. So Murphy's sign, how it is elicited? Murphy's sign is said to be positive when we lay two fingers over the right upper quadrant and we ask the patient to breathe in. And while breathing in, it causes pain to the patient, and there is arrest of inspiration. When the patient is trying to breathe in, it causes pain and there is arrest of the inspiration because an an inflamed gallbladder impinges on our fingers, or it pushes against our fingers during the time of inspiration. Inflamed gallbladder tries to push against the fingers, so it will cause pain to the patient, and as a result there is arrest of inspiration. But it is this Murphy's sign is said to be positive only when this same test is negative on the left upper quadrant, where there is no pain or arrest of inspiration. Now tests because of inflammation, here white cell count and CRP would be elevated. Ultrasound will show thick-walled shrunken gallbladder, thick-walled and shrunken gallbladder. Now management is nil by mouth, analgesia, IV fluids and antibiotics. So management will be the patient has to be nil by mouth in case of acute cholecystitis, and analgesia should be given, IV fluids and antibiotics. Once the symptoms settle, do a laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a treatment of choice for all patients fit for general anesthesia. Open surgery is required if there is gallbladder perforation. So once the symptoms settle down, do a laparoscopic cholecystectomy. Laparoscopic cholecystectomy is the treatment of choice for all the patients who are fit for general anesthesia. Open surgery is required if there is gallbladder perforation. So this is about acute cholecystitis. So what we read here is acute cholecystitis occurs following stone impaction in the neck of the gallbladder, which can cause continuous epigastric or right upper quadrant pain, which is referred to the right shoulder. There can be vomiting, fever, and local peritonism. Occasionally, right upper quadrant mass can also be palpable, which can be inflamed gallbladder or inflamed distended gallbladder or inflammatory mass surrounding the inflamed gallbladder. Main difference from biliary colic is the inflammatory component of acute cholecystitis, that is fever, elevated white cell count, and perotinism. Now, if the stone moves to the common bile duct, it can cause obstructive jaundice and cholangitis as well. Now, Murphy's sign. Murphy's sign is positive when we lay two fingers over the right upper quadrant and ask the patient to breathe in, which causes pain to the patient and arrest of inspiration as an inflamed gallbladder pushes against our fingers. It is only positive if the same test is negative in the left upper quadrant and it does not cause any pain. Tests or investigations would be CRP would be raised, white cell count would be raised, ultrasound will show thick walled, shrunken gallbladder. So, ultrasound will show thick walled and shrunken gallbladder. Management would be nil by mouth, analgesia, IV fluids, and antibiotics. Once the symptoms settle down, we do a laparoscopic cholecystectomy. This laparoscopic cholecystectomy is a treatment of choice for all the patients who are fit for general anesthesia. Open surgery is only required when there is gallbladder perforation. Okay, so about acute cholecystitis, presentation would be acute severe right upper quadrant pain or epigastric pain radiating to the right shoulder, nausea, vomiting, and fever. Murphy's sign, that is pain on deep inspiration as the finger touches the inflamed gallbladder. Most common cause is blockage of the cystic duct by gallstone, blockage of the neck of the gallbladder, or blockage of the cystic duct by a gallstone. Investigation would be ultrasound abdomen. Treatment would be laparoscopic cholecystectomy. Gallstone in an asymptomatic patient offer reassurance. We have to offer reassurance to a patient. If there is gallstone in an asymptomatic patient, offer reassurance to the patient. Now, here we see gallstone in gallbladder and gallstone in cystic duct. So, here is the gallbladder, and we have the neck of the gallbladder, that is cystic duct, and impaction of a gallstone in the neck of the gallbladder. So, gallstone in the cystic duct is mostly a cause of acute cholecystitis. Gallstones in gallbladder may cause inflammation. So this is about. So here in acute cholecystitis, presentation would be acute severe right upper quadrant pain or epigastric pain radiating to the right shoulder. Nausea, vomiting, fever. Murphy's sign is positive, that is pain on deep inspiration as the finger touches the inflamed gallbladder. Most common cause is blockage of the cystic duct by a gallstone. Investigation ultrasound abdomen, treatment laparoscopic cholecystectomy. Now here, gallstone in the cystic duct, gallstones in the gallbladder may cause inflammation. So that is regarding this. Now regarding this specific question here, acute cholecystitis presents with severe continuous right upper quadrant pain which can be seen radiating to right flank and back here. A fever like in this stem is also associated with it. Nausea and vomiting are often seen with cholecystitis. Jaundice can be a feature of obstruction, as we read that if this stone moves to common bile duct instead of cystic duct, if it moves to common bile duct, then it can cause obstructive jaundice and cholangitis. So jaundice can be a feature of obstruction of the biliary tract, and it can be seen in cholecystitis. However, it is often mild and it is not seen unless there is presence of gallstones in the common bile duct, that is cholelithiasis. Cholelithiasis. In this stem, jaundice is absent. Examination here shows a positive Murphy's sign. Remember, Murphy's sign is not just pain, but it is actually the arrest of inspiration when pressing the right costal margin at the mid clavicular line. When we press our fingers, when we place our two fingers on the right upper quadrant along the right costal margin at the mid clavicular line and ask the patient to take deep breath, it causes pain to the patient, and it also causes arrest of inspiration because of inflamed gallbladder pushing against our fingers, impinging against our fingers. So this is positive Murphy's sign, and it is only positive when on the left upper quadrant it is negative. It is a sign of acute cholecystitis. It is sensitive, but it is not specific to cholecystitis. It can also be present in certain other conditions, but it is quite sensitive. Now there is an elevation of ALP in the stem, which ALP rises much higher than ALT, which point towards formation of a biliary obstruction with cholestasis. So here ALP rise is much higher than ALT, which indicates towards biliary obstruction with cholestasis. So elevation of ALP in the stem is there, and ALP rises much higher than ALT, which points towards biliary obstruction with cholestasis. The likely scenario here is that there are gallstones which are obstructing the cystic duct, causing acute cholecystitis. More than 90% of the time, acute cholecystitis occurs from the blockage of the cystic duct by a gallstone. When this occurs, the patient would experience biliary colic. Chronic cholecystitis is incorrect, as chronic cholecystitis occurs when there are repeated episodes of infection causing thickening and fibrosis of gallbladder. In chronic cholecystitis, there would be repeated episodes of infection and there would be fibrosis and thickening of gallbladder. Here, there would be thickening of the walls of the gallbladder and shrunken gallbladder on ultrasound. Acute pancreatitis is also incorrect here, as the amylase is within normal limits in this case. Acute pancreatitis is an inflammation affecting the exocrine function of the pancreas. Commonly, it is caused by gallstone occlusion of the biliary system and alcohol excess. Gallstone occlusion of the biliary system and alcohol excess. There is acinar cell injury leading to both local and systemic inflammatory responses. There is mid-epigastric left upper quadrant pain alongside signs of hypovolemia and elevated pancreatic enzyme levels. Anyway, so acute cholecystitis here presents with severe continuous right upper quadrant pain, which can be seen radiating to right flank and back. Nausea, vomiting are often seen. Jaundice can also be a feature if there is presence of gallstones in the common bile duct, leading to obstructive jaundice, choledocholithiasis, but here jaundice is not there. Uh, Now, Murphy's sign is not just pain, it is also the arrest of inspiration. Murphy's sign, we understood, It is positive here in acute cholecystitis. It is a sign of acute cholecystitis when we place our two fingers on the right upper quadrant pane along the right costal margin in the mid-clavicular line, and we ask the patient to take a deep breath. It causes pain to the patient and arrest of inspiration because of impinging or pressing of inflamed gallbladder against our fingers. This is positive Murphy sign. It is only positive when it is negative on the left upper quadrant, and this test uh, is sensitive, but it is not specific to cholecystitis. Now here, elevation of ALP is more than ALT, which is pointing towards biliary obstruction with cholestasis, and gallstones can be there which are obstructing the cystic duct, causing acute cholecystitis. More than 90% of the time, acute cholecystitis is caused by this blockage of the cystic duct by a gallstone. So when this occurs, a patient would experience biliary colic. In chronic cholecystitis, repeated episodes of infection would be there, and thickening and fibrosis of gallbladder would be there. Okay, so now let's move further. A 48-year-old woman is admitted to emergency with a productive cough and moderate fever. She complains of central chest pain and regurgitation of undigested food. She finds it difficult to swallow both foods and liquids. These symptoms of swallowing have been present for the last 4 months. A chest x-ray shows megaesophagus. What is the most likely diagnosis? So here we are seeing a case of achalasia. So achalasia, and obviously it leads to dysphagia. So our rule number one for dysphagia is dysphagia plus initial investigation is equal to endoscopy. Remember, anyone with dysphagia, the most initial investigation is now an endoscopy. It does not matter if you are considering achalasia or diffuse esophageal spasm, you will get an endoscopy first before a barium swallow. So you may read from books or articles that barium swallow is to be done first if suspecting achalasia or diffuse esophageal spasm, but that is now teaching of the past. In the UK, now we do endoscopy first for patients presenting with dysphagia. The only exception to this rule is when one suspects pharyngeal pouch. If you do suspect pharyngeal pouch based on symptoms, pick up barium swallow, as endoscopy as an initial investigation has a risk of perforation. Now, dysphagia can be, here we can see clearly, dysphagia can be of different types. Now, dysphagia to both solids and liquids is indicating motility problem, which can be intermittent or progressive. Intermittent is diffuse esophageal spasm. Progressive is achalasia and scleroderma. Now, dysphagia, which is initially to solids but progresses to also involve liquids, that is mechanical obstruction. Intermittent is esophageal ring, progressive is peptic stricture and esophageal cancer. So, first rule for dysphagia is always we have to carry out initial investigation as endoscopy. Endoscopy is the initial investigation in anyone with dysphagia. So it does not matter if we are considering achalasia or diffuse esophageal spasm, always we will get an endoscopy first, even before barium swallow. It is it was an old study and it was an old practice to carry out barium swallow before endoscopy. But now in the UK we do endoscopy first for patients presenting with dysphagia. The only exception here is pharyngeal pouch, because if we suspect pharyngeal pouch based on the symptoms, barium swallow should be considered before endoscopy, because endoscopy has the risk of perforation in case of pharyngeal pouch. Now, dysphagia can be to both solids and liquids simultaneously, or dysphagia can be to solids initially but progressing to also involve liquids later. So it can be due to motility problem or it can be due to mechanical obstruction. So dysphagia to both solids and liquids is due to motility problem. So dysphagia to both solids and liquids is due to motility problem. Dysphagia to initially to solids but progressing to involve liquids later is due to mechanical obstruction. Motility problem can be intermittent or progressive. Intermittent diffuse esophageal spasm, progressive achalasia and scleroderma. Mechanical obstruction intermittent is esophageal ring, es- uh, progressive is esophageal cancer and peptic stricture. So now achalasia is idiopathic loss of the normal neural structure of lower esophageal sphincter, which results in failure of relaxation of the circular muscles at the distal esophagus. The lower esophageal sphincter is usually contracted to prevent the acidic gastric contents from refluxing backwards into the esophagus. This is normally a relaxation process. There is normally a relaxation process of lower esophageal sphincter during the time of swallowing, so as to allow the food to pass into the stomach. In achalasia, there is loss of the ability to relax the lower esophageal sphincter. In achalasia, basically there is loss of the ability to relax the lower esophageal sphincter. It occurs due to loss of the normal neural structure of the lower esophageal sphincter, because of which there is failure of relaxation of the circular muscles of the lower esophageal sphincter or distal esophagus. Usually, it is in contracted state to prevent the reflux of the acidic gastric contents into the esophagus. But during the time of swallowing of the food, there is normally a relaxation process of the lower esophageal sphincter, so as to allow passing of food into the stomach. But in echinacea, it does not happen. Presentation would be progressive dysphagia both to both solids and liquids simultaneously, can have regurgitation of stagnant food several hours after eating. There is weight loss, there is nighttime coughing fits, which can be due to aspiration, can result in recurrent lower respiratory tract infection. But echinacea has got no relationship with alcohol or tobacco use, which is different from esophageal cancer. It's not only usually present with dysphagia to solid foods which progress to difficulty in swallowing liquids, but is also more commonly in older patients with a long history of alcohol and tobacco use. Basically, a patient of echinacea has dysphagia to both solids and liquids, some motility problem, diffuse esophageal spasm, and echinacea and scleroderma, and mechanical obstruction. We have esophageal ring, esophageal cancer, and peptic stricture, intermittent and progressive in both. And another thing is, patient can have regurgitation of the stagnant food several hours after eating. Patient can also have regurgitation here. There is dysphagia to both salts and liquids simultaneously. Patient have weight loss. There is nighttime coughing fits. Patient can have recurrent lower respiratory tract infection due to aspiration due to nighttime coughing fits. Uh, but echinacea does not have any relationship with alcohol or tobacco consumption, which is different from esophageal cancer, because in esophageal cancer, which is a mechanical obstruction, the dysphagia is initially to solids, later progresses to liquids as well, and it is usually found in older patients with long history of alcohol and tobacco use. Investigations here which we'll do will be endoscopy. Gold standard is esophageal manometry. Barium swallow is only done if manometry is unavailable. So most initial investigation endoscopy. We know dysphagia, golden rule. Most initial investigation endoscopy. It will not diagnose echinacea, but it is needed for anyone with dysphagia to rule out cancer first. Barium swallow is no more the first investigation to perform before endoscopy. There has been a big switch where endoscopies are now performed first to rule out cancer for anyone with dysphagia. Now, gold standard is esophageal manometry because it measures pressure. The most accurate test overall is esophageal manometry. It shows increased lower esophageal resting pressure. Gold standard here would be esophageal manometry. It is measuring the pressure, and it is the most accurate test overall. Esophageal manometry shows increased lower esophageal resting pressure. Now, barium swallow is only done if manometry is unavailable. Barium swallow will show dilatation of the esophagus with which is narrowing into a beak-like appearance, or bird's beak appearance, we say. So barium swallow shows dilation of the esophagus, which narrows into a bird's beak at the distal end, bird's beak appearance. Management is dilatation of the lower esophageal sphincter in echinacea. Now, dysphagia, if there is dysphagia to both solids and liquid, it is a motility problem. Diffuse esophageal spasm, echinacea, and scleroderma. If dysphagia is initial to solids, progresses to liquids later, it is most likely a mechanical obstruction, that is esophageal ring and esophageal cancer and peptic stricture. Once the distinction has been made, it is important to differentiate whether it is intermittent or progressive. Diffuse esophageal spasm is intermittent. Echinacea and scleroderma are progressive. These are motility problems. Mechanical obstruction, esophageal ring is intermittent. Esophageal cancer and peptic stricture are progressive. Only situation we will pick barium swallow as the initial investigation is a pharyngeal pouch. Endoscopy as the initial investigation for pharyngeal pouch have risk of perforating the lesion. Endoscopy is done first in cases of dysphagia to rule out cancer. That is the takeaway message, big takeaway message here. So another thing here is this table. Now esophageal cancer, here there is dysphagia to solids first before liquids. There is weight loss, history of smoking, alcoholism. Smoking can lead to squamous cell carcinoma, Barrett's esophagus. It can lead to adenocarcinoma, stenting if inoperable to help with dysphagia. Okay. Achalasia cardia, dysphagia to both solids and liquids. There is regurgitation of food, bird's beak appearance in barium swallow, high resting pressure of lower esophageal sphincter in esophageal manometry. Now diffuse esophageal spasm. In this dysphagia to both solids and liquids, we will see corkscrew pattern in barium swallow. Intermittent abnormal peristalsis in manometry. Intermittent abnormal peristalsis in manometry. So esophageal cancer, dysphagia to solids, then liquids. There is weight loss, history of smoking and alcoholism. Smoking can lead to squamous cell carcinoma. Barrett's esophagus can lead to adenocarcinoma. Stenting can be done if inoperable to help with the dysphagia. Now achalasia cardia, dysphagia to both solids and liquids. Regurgitation of food is there. Bird's beak appearance. We'll see bird's beak appearance in barium swallow and high resting pressure. In esophageal manometry, we'll see high resting pressure at the lower esophageal sphincter in esophageal manometry. Diffuse esophageal spasm, here we will see corkscrew appearance in barium swallow. In diffuse esophageal spasm, we will see corkscrew appearance. Corkscrew appearance in barium enema. Dysphagia to both solids and liquids, okay. And here we will also see intermittent abnormal peristalsis. Intermittent abnormal peristalsis in esophageal manometry. Okay, now last is Zenker's diverticulum. In this, there will be regurgitation of the food. There will be halitosis. Pouch will be seen on barium swallow. Now here we'll see a pouch. So Zenker's diverticulum, regurgitation of the food is there, halitosis is there. That is bad smell in breath. So Zenker's diverticulum, regurgitation of food is there, halitosis is there, and pouch is seen on barium enema. Or sorry, barium swallow. A pouch is seen on barium swallow in Zenker's diverticulum. Okay, let's go through the investigations here. So esophageal dysphagia, endoscopy is done first, and plus minus esophageal biopsies. Now, if it is structural, if structural abnormality is detected, examples ring, web, or tumor. If it is normal, then dysphagia to solids alone. Then we'll carry out barium swallow. And if dysphagia is not just to solids alone, then we'll carry out manometry. Now, barium swallow can be normal, or it can show structural abnormalities which we missed on endoscopy earlier. It can be ring, web, or tumor. Now, if it is normal, we'll carry out esophageal manometry. It can show motility disorders, or it can be normal. If it is normal, then there can be something else. If motility disorders are detected, it can be diffuse esophageal spasm or echalasia. So this is how we'll investigate for esophageal dysphagia. First, endoscopy plus minus esophageal biopsies. Now, either it can be positive, it can show structural abnormalities such as esophageal web, esophageal ring, or tumor, or it can be normal. Now, if it is normal, then dysphagia, if dysphagia is just to solids alone, then we'll carry out barium swallow. If dysphagia is not just to solids, then we'll carry out esophageal manometry. Now, barium swallow can show the structural abnormalities which we missed on endoscopy, such as esophageal ring, web, and tumor, or it can be normal. If it is normal, then further we'll carry out esophageal manometry. Manometry can either show motility disorders such as diffuse esophageal spasm or echalasia, or it can be normal, then it shows something else. So this is about echalasia and dysphagia. The diagnosis here is echalasia. It can sometimes present as chest pain. The productive cough in this quotient points towards aspiration pneumonia, which is secondary to retained food. The productive cough in this quotient points toward aspiration pneumonia, secondary to retained food and fluid in the esophagus. Regurgitation of undigested food and difficulty in swallowing both foods and liquids are classical for echalasia. A chest x-ray would also show a large esophagus in echalasia. While some might argue that the answer could potentially be pharyngeal pouch due to regurgitation of undigested food and aspiration pneumonia, the writers of the exam would provide other hints if pharyngeal pouch was the answer, such as halitosis, which may occasionally be seen in a pharyngeal pouch. Furthermore, megaesophagus points towards echalasia as being the answer for this question. So here, chest X-ray is showing megaesophagus. So usually in echalasia, due to the high pressure of the lower esophageal sphincter, the esophagus is dilated and shows bird's beak appearance. So we have megaesophagus in echalasia. And further, it is showing productive cough in the quotient towards, it is pointing towards aspiration pneumonia. So due to nighttime coughing fits due to aspiration of regurgitated food, undigested regurgitated food, which can lead to aspiration, it can lead to recurrent lower respiratory tract infections and difficulty in swallowing both foods and liquids. So this is all classical for echalasia. If pharyngeal pouch was the answer, we would have other options like halitosis and all. Pharyngeal pouch. Pharyngeal pouch is a pathology brought about by structural or physiological abnormality associated with cricopharyngeus muscle. It is typically found in older patients, presents with dysphagia, regurgitation, aspiration, and weight loss. Dysphagia, regurgitation, aspiration, and weight loss. Barium swallow studies are used to diagnose its presence and it is managed surgically. However, this is associated with significant morbidity due to the surgery itself, but also due to the comorbidities of the patients undergoing it. So, it is basically associated with abnormality in the cricopharyngeus muscle, and we will have dysphagia, regurgitation, weight loss, aspiration, and it is managed surgically. And barium swallow is the investigation in pharyngeal pouch. Okay, let's move further now. Now, here we have a 39-year-old patient who was recently diagnosed with celiac disease and has been treated with a gluten-free diet for 2 years. He now has an exacerbation of the classical symptoms of celiac disease, such as abdominal pain, diarrhea, has also lost significant weight. Biopsy of the small intestine shows lymphomatous infiltrates. So now we'll study about celiac disease. First of all, celiac disease is an autoimmune condition caused by sensitivity to the protein gluten. Repeated exposure to gluten, rye, wheat, barley leads to villus atrophy, which results in malabsorption. Chronic, clinical features of this celiac disease are: first, we understood it is an autoimmune condition. Celiac disease is an autoimmune condition caused by sensitivity to the protein gluten. Autoimmune condition caused by sensitivity to the protein gluten, and repeated exposure to gluten, rye, wheat, barley can lead to villus atrophy and leading to malabsorption. Now, clinical features are chronic or intermittent diarrhea, stinking stools, steatorrhea, persistent unexplained GIT symptoms including bloating, nausea, and vomiting, fatigue, unexpected weight loss, unexplained iron, vitamin B12, or folate deficiency. One of the most common presentations of celiac disease is iron deficiency anemia. Also, folate deficiency is more common than vitamin B12 deficiency in celiac disease. In children, tapering growth may be seen. So, clinical features are chronic or intermittent diarrhea, stinking stools, steatorrhea, and unexplained GIT symptoms like bloating, nausea, and vomiting, fatigue, unexplained weight loss, iron deficiency, folate deficiency, vitamin B12 deficiency. Most common presentation in celiac disease is iron deficiency anemia. In children, tapering growth is seen. Now, complications of celiac disease are osteoporosis and T cell lymphoma of small intestine. Investigations: specific autoantibodies, and jejunal or duodenal biopsy. Specific autoantibodies are TTG antibodies, which are IgA type, are the first choice according to NICE guidelines. Tissue transglutaminase, TTG antibodies, that is tissue transglutaminase antibodies, which are IgA type, are the first choice according to NICE. Second are endomysial antibody, that is IgA antibody. So specific autoantibodies are TTG antibodies, that is tissue transglutaminase antibody, which are IgA type, first choice. Second, endomysial antibody, IgA type. Jejunal or duodenal biopsy is still needed to diagnose celiac disease if antibody tests are positive for celiac disease. For seeing villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes. So in biopsy, we see for villus atrophy, crypt hyperplasia, and increase in intraepithelial lymphocytes. The serological tests or biopsies for celiac disease are not accurate if a gluten-free diet is eaten during the diagnostic process. Therefore, patients should not start a gluten-free diet until celiac disease is confirmed, which is often distressing to patients as they would continue to be symptomatic. So biopsy has to be done even after antibody tests so as to confirm the celiac disease, even after antibody tests are positive. And these serological tests or biopsy tests, they are not accurate if a gluten-free diet is eaten. Therefore, patient has to have avoid or patient should not start a gluten-free diet until celiac disease is confirmed after doing biopsy and serological tests. So it can be distressing to patients that they would continue to have symptoms. If patients are already taking a gluten-free diet, advise to reintroduce gluten for at least 6 weeks prior to testing. If they are already having a gluten-free diet, then we have to advise them to start to introduce gluten in their diet, to start gluten containing diet at least for 6 weeks before the test. Management is gluten-free diet. So it is a malabsorption syndrome due to inflammatory response to gluten present in wheat, rye, and barley. It is a malabsorption syndrome which occurs due to inflammation response or sensitivity to gluten, protein gluten present in wheat, rye, and barley, leading to villus atrophy and leading to malabsorption. Presentation: chronic intermittent diarrhea, fatty stools, staturia, abdominal distension, nausea, vomiting, unexplained symptoms like bloating, then chronic fatigue, weight loss, malabsorption of vitamins and minerals, iron, B12, iron, folate, and B12 deficiency, skin manifestation, dermatitis, herpetiformis. Skin manifestation of celiac disease is dermatitis, herpetiformis, seen on extensor aspects. Investigation are specific antibodies. These are specific autoantibodies because this is an autoimmune condition, celiac disease. So specific antibodies, tissue transglutaminase antibody, and second, endomysial antibodies, anti-endomysial antibodies. Second are biopsy or serological tests, biopsy, duodenal or jejunal biopsy, which are confirmatory. These are done to confirm the diagnosis. Duodenal or jejunal biopsy, which are confirmatory, they have to be done even after antibody tests are positive. So we, in the biopsy, duodenal jejunal biopsy, we look out for villus atrophy and crypt hyperplasia and increase intraepithelial lymphocytes. Management is gluten-free diet. For the test to be accurate, the patient should still be having gluten in their diet. If the patient is already on gluten-free diet, gluten should be introduced for at least 6 weeks before testing, because these tests are not correct if they are on gluten-free diet. Okay, so now let's take a break for a while and we'll resume.